Matteo, thanks for coming here in Vienna. You're from Italy. You've been looking at avoiding premature ovarian failure. Tell me about your centre and what your position is in that centre.
Yeah, I'm still a fellow in medical oncology. I'm completing my residency. I have just a few months left. And I work with Dr. Del Mastro in the Department of Medical Oncology at the San Martino East in Genova, Italy.
Now, why were you so interested in looking at breast cancer therapy for younger patients and the difficulties it makes for them if they want to have a baby?
Yeah, because breast cancer in young women occur in approximately 11% of all cancer diagnosed every year. And one of the side effects of chemotherapy in this young patient is the possible occurrence of premature ovarian failure and subsequent infertility. And a lot of these patients still desire to have a pregnancy after cancer treatment. And so this is a very important topic.
So what did you do in the study?
We perform a meta-analysis of randomized studies to evaluate the role of temporary ovarian suppression with an hormonal agent called LHRHa analog administered during chemotherapy as a strategy to preserve ovarian function and fertility in young breast cancer patients.
There are alternatives if you want to have babies though, aren't there?
Yeah, the standard strategies to date for fertility preservation in cancer patients are cryopreservation of embryos or oocytes. These are the standard strategies, but these strategies can preserve fertility, so the possibility to have babies in the future, but not the overall ovarian function, and so patient might be still at risk of developing early menopause.
So what are the benefits potentially of using temporary ovarian suppression rather than going for cryopreservation and just going ahead with your chemo?
So the major advantage is that the LHRHa can preserve not only fertility, so the possibility to have babies in the future, but mainly ovarian function, and so trying to avoid the risk of going into menopause in early menopause.
So what did you find?
So we found that the use of LHRHa was associated with a statistical reduction in the risk of developing premature ovarian failure, defined as in each eligible studies, but also we found that the use of LHRHa reduced statistically significantly the number of patients developing one-year amenorrhea, and also we found a higher number of patients achieving pregnancy after treatment with the use of this strategy as compared to those who received chemotherapy alone.
And the numbers are quite impressive, aren't they? Because I seem to remember you sort of halved the incidence of premature ovarian failure.
Yeah, we found a weighted odds ratio of 0.36. That means a 64 reduction in the risk of developing this side effect.
And to prove the point, some of your women got pregnant.
Yes, 33 patients across all the studies in the LHRHa analog arm achieved pregnancy as compared to 19 in the control arm, so in patients receiving chemotherapy alone.
Right. Now, is there a downside to using LHRH agonists as therapy?
The LHRH agonists, their action is to make a kind of pharmacological menopause, and so patient might suffer of some side effect of menopause, such as hot flashes or sexual dysfunction. However, the use of this strategy is just for the 5-6 months of chemotherapy, and so this might not impact too much on the quality of life of this patient. And there are only 2 trials reported adverse event with the LHRHa in these studies, and they did not find any significant difference in side effects between patients enrolled in the chemotherapy alone arm as compared to those in the LHRHa arms.
And of course, if you use temporary ovarian suppression, you don't have to delay your chemotherapy.
No, that's true. This strategy can be started just the day before the initiation of chemotherapy and then administered for all the duration of treatment.
So what are your recommendations to doctors who might be advising young women patients about their treatment for breast cancer, many of whom, I gather, as many as half, still want to have a baby?
For patients who are really interested in preserving their fertility, embryo and oocyte cryopreservation are still the standard strategies for fertility preservation and the strategy with the most reliable results. However, in this patient and also in those who are interested in maintaining ovarian function more than fertility, who are afraid of developing early menopause more than the need to have a baby still a baby in the future, For this patient, the use of LHRHa might be considered a valid option to preserve their ovarian function and might be used also in patients who underwent prior oocyte or embryo cryopreservation to improve their chances to have babies in the future.
So could you summarize the brief main points coming out of this?
We found that the use of temporary ovarian suppression with LHRHa during chemotherapy was associated with a statistically significant reduction in the premature ovarian failure rate and with a higher pregnancy rate with no impact on disease-free survival, although only 3 studies among the 12 included in our meta-analysis reported disease-free survival events.